payers don't have a you must do, right? There's no government guidance, similar to an HTA body of you have to have this to reach this level of approval or this level of reimbursement or acceptability. We don't have that, right? It really comes down to individual payer preference and kind of the way they work and what they want to see. This changes year to year and month to month and day to day as things evolve, which again makes it another level of complexity that different payers have different evidence needs and preferences, but no formal requirements. It's not all laid out on a silver platter, unfortunately. But some of this transparency is increasing, hopefully, as we get there. They can vary, as mentioned, kind of widely between archetypes, organizations, even individual payers. If you talk to two different payers at the same organization and do, in-depth interviews with them, I've heard complete opposite ends of the spectrum talking about the same exact drug and what they'd want to see, right? So there are so many layers here. And it also varies widely between disease states, right? There might be more flexibility in what they're open to and seeing with rare disease states where surrogate endpoints might be okay, right? They just want to see something and have some kind of patient improvement. Really established disease areas, those surrogate endpoints, right? They're not going to fly, or things like oncology, right? They might be okay with some of the surrogate endpoints to start with. They might be okay with progression-free survival to start, but they'll want to see overall survival if you continue to come back for access and look at as the landscape gets more competitive and more therapies come to market and you've been on, commercially available for 3 years, they're not going to want to continue to see PFS. And that's where things like real world evidence really comes into play and continuing to, generate evidence and value for a product.